Welcome to this explainer. Today, we're taking a fascinating anatomical road trip down the human arm to unpack one of its most critical structures. We're going to break down the ulnar nerve, its exact route, what it supplies, and some really interesting clinical implications. Let's dive right in.
So why does hitting your elbow cause that sudden, shocking tingle all the way down to your pinky finger? We've all smacked our funny bone at some point, right? Well, spoiler alert, it isn't a bone at all. That electric jolt perfectly introduces the star of today's journey, the ulnar nerve, getting briefly pinched against your elbow.
Here's our roadmap for today. We'll meet the ulnar nerve, map its route, look at its motor and sensory supply, explore Guyon's canal, hit some clinical checkpoints, and finally, unpack the fascinating ulnar paradox.
Section 1. Meet the ulnar nerve, also known as the musician's nerve.
The ulnar nerve is a major peripheral nerve of the upper limb, drawing its vital fibers directly from the C8 and T1 spinal roots. We often call it the musician's nerve because it's absolutely essential for the intricate, fine motor control of the hand. It's what gives you the exact dexterity you need to play a piano or guitar.
Notice where the magic actually begins. Right here in the axilla, the armpit region. The nerve first takes shape as a direct continuation of the medial cord of the brachial plexus before it heads down the arm.
Section 2. Mapping the route, the anatomical highway.
You can basically think of the nerve's route in 4 major steps. It originates up at the brachial plexus, travels down to pass behind the elbow through the ulnar tunnel, dives under the muscles of the forearm, and finally squeezes through a tight space in the wrist called Guyon's canal. Keep in mind, the elbow and the wrist act as critical, and sometimes incredibly congested, transit points.
Following its path, you can see how the nerve travels down the medial or inner side of the arm. Check out how it passes posterior to the elbow joint. That is the exact spot where it's exposed and vulnerable to getting bumped, which is exactly what triggers that funny bone phenomenon we talked about earlier. From there, it dives deep into the forearm right alongside the ulna bone.
Section 3. Motor and sensory supply, power and feeling.
Let's break out its motor functions from its sensory supply. In the forearm, the nerve is actually pretty economical. It only powers 1.5 muscles, the flexor carpi ulnaris and the medial half of the flexor digitorum profundus, or FTP. But down in the hand, that's where it shines. It's the absolute powerhouse for your intrinsic muscles, driving the hypothenar muscles, the interossea, and the adductor pollicis.
Now, what's really interesting is the sensory distribution. Visually, this sensory zone is remarkably distinct. It's isolated strictly to the pinky finger and just the medial half of the ring finger, and that applies to both the palm side and the back of the hand. Because this area is so specific, if you ever lose feeling exactly in this zone, it's a massive red flag for doctors to immediately suspect the ulnar nerve.
But hey, this is human anatomy, so of course there are exceptions. Keep in mind that anatomical variations, like anastomoses, which are basically connecting branches, frequently occur between the median and ulnar nerves in the forearm. Because of these crossing cables, a nerve injury in the forearm might not always cause the expected changes in the hand. That can make clinical diagnosis incredibly confusing, even for seasoned physicians.
Section 4. Guyon's canal and the hand, the final toll booth.
Right at the base of the palm, there's a tiny 40 to 45 millimeter tunnel that extends from the pisiform bone over to the hook of the hamate. It houses the ulnar nerve and the ulnar artery. Because it's such a tight, rigid space, it's a notoriously common site for nerve compression, leading to a condition known as Guyon's canal syndrome. Inside this tiny canal, the space is actually divided into 3 specific zones. And this is crucial. Depending on exactly where a compression or traffic jam occurs in these 3 zones, a patient's symptoms will change dramatically. They might present with purely sensory tingling if the pinch is in zone 3, purely motor weakness if it's in zone 2, or a mix of both if the block happens earlier in zone 1.
Section 5. Clinical checkpoints, lesions, and palsy.
A really classic sign of ulnar nerve palsy is the resting claw-hand deformity, where the ring and little fingers are stuck in this awkward hyperextended and flexed position. Another dead giveaway is a positive Froment sign. Because the ulnar nerve powers the adductor pollicis muscle in the thumb, someone with damage here literally cannot grip a piece of paper flatly between their thumb and index finger. They have to awkwardly bend their thumb to compensate for the weakness.
So, the crucial point clinically is figuring out exactly where the injury happened.
A high lesion at the elbow is by far the most common site of injury, often due to a fracture of the medial epicondyle. Because the injury is so high up the chain, it knocks out all downstream muscles, including those forearm flexors we mentioned earlier. This leads to weak wrist flexion and visibly flat muscle wasting on the side of the palm.
Section 6. The Ulnar paradox, a medical mystery solved.
Now, this is completely counterintuitive. You logically think that a severe high-level injury at the elbow would cause a much worse-looking claw hand deformity, right? Well, it doesn't. A high injury actually looks significantly less deformed. Why? Because the forearm muscle, the FDP, that pulls the fingers down into a tight claw, is also paralyzed. Conversely, a lower injury at the wrist leaves those forearm flexors fully intact, so they forcefully pull the fingers into a much tighter, prominent claw. The classic memory trick: the closer to the paw, the worse the claw.
We'll end our explainer today with a thought to chew on. We've seen how the ulnar paradox can completely deceive the eye, and how crossing nerve fibers can scramble a patient's symptoms. So considering the ulnar paradox and these unique nerve variations, how might undetected anastomoses completely change a surgeon's approach to treating hand trauma? It's a highly complex system that just proves we still have so much more to explore about the brilliant, intricate engineering of the human body. Thanks for joining this anatomical road trip, and keep questioning the incredible mechanics right under your skin.